The lifetime risk for hip fracture for a woman is about 1 in 7, which is higher than their lifetime risk of breast cancer. The lifetime risk of breast cancer is about 1 in 9. So actually the lifetime risk of a hip fracture is higher. If you look at all osteoporotic fractures like spinal compression fractures, wrist fractures is much higher. Also the death rate from fractures, or at least let me rephrase that, if you take all folks who have hip fractures, about 25% of them pass away within a year. So if you look at the mortality associated with hip fracture, it's actually higher than breast cancer. We don't have any ribbons for hip fractures, but the overall risk for osteoporotic or hip fractures is very, very high. There's a large number of risk factors for hip fracture. The most common is being female, and then age is also a predisposing risk factor. In fact, the risk of hip fracture rises exponentially after age 65, and then osteoporosis is obviously a risk factor also. The thinner your bones and the frailer your bones, the more likely you are to fracture. That's also increased by whatever your risks for falling are, which can be increased by things like visual impairment, hearing impairment, and also from other medical illnesses like heart disease, stroke. Those sorts of things increase your risk of fractures as well. So hip fractures generally happen in sicker, frailer, older individuals, and they happen more often in women than in men, happen more often in Caucasians than in African Americans. The environment you live in also can be a risk factor. Loose carpeting, poor shoes, small animals, debris, anything that can get in your way and increase your risk of falling will also increase your risk of hip fracture. The typical hip fracture patient usually comes to the hospital sometime in the evening. One of the most common scenarios is the patient was getting up from the bed at night to go use the bathroom, and because the lighting is poor, there might be objects in the way, or they might forget to use their walker or forget to use some other type of assist device, they fall. They're also in a hurry, and they don't wait to make sure that their blood pressure and heart rate equilibrate before they get up from the side of the bed, and so they fall going to the bathroom. Typically within a couple of hours somebody finds out about it, or they're able to notify somebody. They end up in the emergency department, and from there most patients end up needing surgery. At Highland, our goal is to get everybody through surgery within 24 hours. That's not typical across the country, but certainly at Highland Hospital, better than 70% of our patients we try to operate on in under 24 hours. Then at Highland, our patients are in the hospital for about 3 or 4 days, and then they usually go to rehab. 92% of our patients will leave the hospital to go to rehab usually at a nursing home, and they're at the nursing home for rehab anywhere from a few to several weeks. Only about 25% of patients get back to their original functional status. About 75% of patients have some ongoing disability or decline, and 20 to 25% of patients will end up in long-term care after a hip fracture. So a hip fracture is what we call a sentinel event. It's a statement. Just the fact that they had a fracture is a statement that the patient has other complications and may not do well. Probably the most important complication that we think about is thromboembolic disease, or DVT. So DVT stands for deep venous thrombosis. A deep venous thrombosis can break off and become a pulmonary embolism, and that can cause sudden death, can cause shortness of breath, and can cause other complications. So that's the one really big complication that we're very frightened of. And almost all patients that have hip fractures get some type of prophylaxis against thromboembolic disease, usually warfarin or low molecular weight heparin. So almost everybody will get some type of prophylaxis for clots. The other complications that can happen are infections of the wound, breakdown of the wound. The wound can open up. Sometimes people can get infections of the prosthesis that we put in, the pins or the other parts that we put in can get infected. Those are very serious complications also. The other things that we see are sort of more minor things. After hip fracture surgery, patients usually have some pain. Pain can lead to complications of pain medication like constipation. Sometimes it can lead to urinary retention. Sometimes people will end up with urinary tract infections from being in the hospital. Occasionally people will end up with complications of pneumonia. So there's a number of complications that are common to older adults that go to the hospital for any particular reason. And we see all those things in hip fracture patients as well, with the special complications being thromboembolic disease and wound-related infections. Sometimes we see pressure ulcers also, especially if people have mobility problems after a hip fracture.
Suspect a hip fracture in the fall of any adult over the age of 65 or 70. You just need to begin to think that even if they're not complaining of any pain in the area of the hip, you need to suspect it, and you need to assess carefully for it. Is there pain on palpation? Is there pain when I gently rock the pelvis? Are the feet going the right direction, or is one of them rotated internally or externally? You need to have that very high index of suspicion anytime over the age of 65 when a person falls, because the hip fracture is very common, and because they are an older adult, they might not feel the pain. They might not realize that they fractured their hip. There have been cases of people who have walked around on a fractured hip for a day and a half before somebody decided that they needed to be x-rayed, and it was evaluated and discovered, yes, they indeed fractured their hip. But because they did not have the pain, it wasn't realized. So you need to suspect it anytime you have an older adult who has a fall. You need to at least assess for it and look for the pain and the potential deformity. The key physical findings for hip fracture. I'm amazed at the number of hip fractures that get diagnosed at the nursing home from the portable x-ray, and then they call EMS. So this is a person who will have fallen overnight. The staff at the nursing home moves them back to the bed, calls for the portable x-ray in the morning. Portable x-ray shows up, takes the picture. Later in the day, it comes back, yes, they fractured a hip, now let's take them to the hospital. So, and what amazes me about that is that the signs for it might be so subtle. The external rotation is just so slight, and the pain is just not really there during the assessment, that it's difficult to detect the minor hip fractures some of the time. So it's can be a very subtle injury, and you need to have that high index of suspicion. Anytime that a family member reports that they seem to have more difficulty walking than before, how could a person walk on a broken hip? They can, particularly if it's a small fracture. So that's something that you need to keep in mind and have that very high index of suspicion. It's really any fall, any kind of pain near the hip. Classically, we talk about the hip being, or the foot being internally rotated for fracture or dislocation, and externally rotated as well, as opposed to being straight. Does it matter whether it's a dislocation or a fracture? No. Pre-hospitally, we're going to treat it the same. And so you want to look at the feet and make sure that they're going in their natural anatomic direction. If there's any variation of that, we need to suspect that we may have a hip fracture. And just remember that the older and more brittle they are, the more likely they are to